This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Delighted you're with us today. Today we want to talk about a topic. If you're thinking about getting pregnant or if you are pregnant, it's very important. And that's when your blood pressure could spike or go up. We're delighted that we've got Dr. Theresa Patton with us, who deals in women's health care, and she's affiliated with the Methodist healthcare system here in Dallas. Dr. Patton, welcome to the show.
Thank you so much for having me.
To help our listeners understand what we're talking about, what is the medical terminology related to blood pressure issues that women face during pregnancy?
So the medical terminology for blood pressure that develops during pregnancy, it's called preeclampsia. You can have high blood pressure outside of pregnancy that then worsens and becomes a form of preeclampsia while you are pregnant, and we tend to refer to that as superimposed preeclampsia. So all kind of the same disease process, but on a spectrum of the way it presents during pregnancy.
Is postpartum different than pre?
So it's interesting that we are talking about postpartum preeclampsia because it's become a bit more recognized in our field as being slightly different than preeclampsia that happens during pregnancy. Postpartum preeclampsia can be a continuation of blood pressure problems that you're having while you're pregnant, but for a small percentage of women, you can also not have any issues during your pregnancy and delivery and then develop the same signs of preeclampsia after you go home from the hospital. And so we're always looking for those signs to develop, especially if you are early in your reproductive years, so younger patients or older patients in their reproductive years, and especially if it's their first pregnancy, because those are some of the biggest risk factors for preeclampsia, no matter when it happens.
Are there other risk factors that women should look for potentially regarding this problem?
So if you have preeclampsia in a previous pregnancy, we're always going to be on the lookout for it, although we have learned in recent years that potentially being on a baby aspirin can help prevent the development of preeclampsia in pregnancy and postpartum. The reason we've been really focused on postpartum preeclampsia, particularly in the state of Texas, is because we have a high maternal morbidity and mortality, particularly for women of color. And so we've been much more focused on the postpartum period and how to prevent some of those bad outcomes. And in women, particularly in the state of Texas, one of the highest risks for having negative outcomes and death in that first year after delivery is cardiovascular disease and hypertension disorders, which includes that postpartum preeclampsia.
You know, you mentioned the maternal mortality rate in Texas, and you're so correct how it impacts minority women. Does this tend to run more in minorities?
So actually everybody's at risk for preeclampsia. I think there are many factors that go into why women of color have an increased risk for morbidity and mortality. In particular, preeclampsia kind of gets all comers.
Is preeclampsia hereditary? By that I mean, if your mother had it, does that mean a daughter may have it?
So that isn't on our list of risk factors. What I will say, though, is that high blood pressure outside of pregnancy definitely has a familial tendency. And so if you have high blood pressure outside of pregnancy and you become pregnant, then your risk for preeclampsia is much higher.
I read an article once that said sometimes this can be so serious that people have convulsions. Is that true?
It is. So in pregnancy, we call it preeclampsia because when it develops to the point of a seizure, then that is actually termed eclampsia. So the preeclampsia is the signs and symptoms that you have before it gets to affecting your neurologic system, which is what can cause the seizures. Now, preeclampsia also affects many other systems of the body. So it can affect your liver, it can affect your kidneys. So there are many things that it can cause, and it affects the entire body.
So this is one of the things you as a physician would look for in the prenatal care, correct?
Absolutely. So that's why if you're pregnant, and pregnant women know this very well, every time they come into the office, they leave us a urine sample where we're looking for protein in their urine. We check their blood pressure every visit. And if it starts to creep up, then we're going to start seeing them more frequently.
We know good prenatal care is important. Are there other things women can do to reduce risk?
So, for many years, we've been looking for what causes preeclampsia, and we just don't know the exact answer yet. And so, women are told to have a low-salt diet. Well, that doesn't really impact this. They're told to be healthy and exercise. Well, that doesn't really impact your risk for preeclampsia. So the most important thing you can do when it comes to preeclampsia is to get early and frequent prenatal care. And then once you have the baby, don't just think you're done. You need to continue to see your doctor as frequently as is recommended, because that's where we pick up some of the postpartum preeclampsia. And if you ever feel just off, particularly after you have a baby, then you need to be picking up the phone and calling your doctor. Part of the reason that I think we have a problem in the state of Texas is that we don't have an expansion of Medicaid into that postpartum period for any length of time. And so a lot of women will stop seeing their doctor because they don't have coverage anymore, and that's when patients can get in trouble.
You make an excellent point, and all of our hospitals certainly care about postpartum care, the real concern on maternal mortality. And speaking of post-delivery, how long before women are really out of danger for this risk?
So preeclampsia tends to, if it hasn't developed in pregnancy, if it's going to happen postpartum, it tends to happen very early in that postpartum time period. However, there are other cardiovascular diseases that can develop after delivery, including postpartum cardiomyopathy, where the heart dilates and doesn't work the way it's supposed to. And those things can happen anytime in that first year. And so continued care after those first few weeks after delivery is really important.
Dr. Patton, my two granddaughters both were born under this, so I've had some scary moments. So first of all, one of the things that I was wondering is, if mom has this before delivery, are there any stats about whether that child will be delivered prematurely?
So it really depends at what stage in the pregnancy preeclampsia delivers preeclampsia presents. And so if it happens very early in pregnancy, then yes. There are several different categories of preeclampsia. There are certain symptoms that put you kind of in the mild category. And when you're in that situation before 37 weeks, then we tend to try to hold off on delivery. But then after 37 weeks, even if you have mild preeclampsia, we usually move towards delivery. Now, if you have several things that kind of push you over into the severe category, certainly eclampsia affecting those other organs like I talked about, then in those situations, we would move towards having a baby even if you're before that 37-week time frame. So yes, moms who develop this early in pregnancy are definitely at risk for preterm delivery.
This great information you've been hearing is coming from Dr. Theresa Patton at Methodist Dallas Medical Center. My family has grandbaby number 3 on the way, and we are keeping an eye on this very topic. Next, would you like to give the gift of life? We're going to tell you how. Abdominal transplants, next on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. And we want to talk today a little bit about organ transplants and specifically kidneys. We've got with us today Dr. Johanna Baylor, who is an abdominal transplant surgeon at Baylor Scott and White All Saints Medical Center in Fort Worth. Dr. Baylor, welcome to the show.
Thank you so much for having me.
We all know that here in the Metroplex, we've got a lot of good transplantation going on, and Baylor Scott and White has an excellent reputation. How does this apply specifically to abdominal transplantation?
In the field of abdominal transplantation, we offer liver, kidney, and pancreas transplantation in Fort Worth as well as in Dallas. And our Dallas location also offers, in addition, uterus and outer islet transplantation to our patients. One of the main focuses for both of our centers is that we keep the patient at the center of everything we do, from care we provide by our physicians to nurses, researchers, coordinators, and always the patient is really the forefront of our mind.
I know you deal with different organ transplant facilities. Does that impact in any way how care is delivered?
Our care that we deliver to our patient is very similar across both of the locations. A lot of our protocols are streamlined between the two locations, so there's not a lot of difference. There is a little bit of difference from a provider standpoint because certain providers are more Dallas-based than others are more Fort Worth-based. But I would say our transplant care and chronic disease care is very similar, and we really consider ourselves one program with two locations in Dallas as well as in Fort Worth.
I know your particular focus is abdominal transplantation, and especially with living donor transplants. Can you help explain this to our listeners?
This is a great question. So when we look at the world of abdominal transplantation, there's an ever-growing number of patients that are waiting for an organ transplant according to UNOS. Currently, there are more than 100,000 people waiting in the U.S. for an organ transplant. 89,000 of those are waiting for a kidney and more than 10,000 for a life-saving liver transplant. And while the list of patients waiting for an organ transplant is ever growing, there is not enough organs for transplant. So what ends up happening is because patients end up waiting for a very long time, they may end up being too sick to transplant and then have to be removed from the transplant list. So one of our focuses here at Baylor is to really expand on living donor transplant because we think this is a great option for our patients to a lot of times get transplanted sooner with the best quality organs and then lead to better outcomes for our patients.
So for our listeners to understand the living donor, would that be like when you found an appropriate match that maybe a sister could give a kidney to a brother, etc.?
Anybody can be a living donor. What we do a lot for our patients when they come through the evaluation process during their pre-transplant evaluation, we educate them on what does it mean to have a living donor and that really anybody can be a donor. We encourage them to share their story with their friends, family, their community, maybe their church. Sometimes we have patients who step forward who want to be a donor who do not even know a particular person that is in need of a transplant, but they feel the need or they want to help. And so they volunteer to basically be an organ donor, and then we can help them find somebody that could benefit from their gift. And that's very unique.
That is unique. And I know we're talking about kidneys, but can you do living donor related to liver as well?
Yes, you can do living donor related to liver as well. And both of those things we offer at our program. People can donate part of their liver for living donation. Their liver will actually grow back. And so somebody who has a healthy liver can donate more than half of their liver to somebody in need. A recovery from the actual surgery will have no long-term effects of having donated a liver.
When you think in terms of a living donor, and anyone could be one, how does someone actually go about becoming a living donor?
I would say the majority of people, they know somebody that is in need for example, of a kidney transplant. They step forward and we have a website that they can apply to, brief screening questionnaire to make sure, they meet certain criteria, and then they get contacted by one of our coordinators, get educated, and if they're interested in proceeding, we bring them in and do a very thorough medical evaluation to make sure that it's safe for them to proceed with donation. And a lot of times the person knows somebody who needs a kidney transplant, but as I say, sometimes we have people who step forward who don't know anybody, or they may have heard about somebody over social media or somebody in their community who's in need.
As far as being a living donor, that's not something that you would put on a driver's license like a normal transplant donor, correct?
It is different than when people register to be an organ donor on their driver's license to be an organ donor after they're, brain dead. It's really just somebody who makes the decision to becoming a donor, and then the patient contact usually the transplant program directly.
What age generally would be the age that would be an ideal living donor?
So if we're talking about kidney donors, so in general, we have a minimum age somebody has to be is 18. But even the other thing is particularly when we have patients who are people who step forward who are very young to donate, we want to make sure that they're mature enough to understand the decision that they're making, because it can be a decision that affects them for the rest of their life. There's no strict cutoff from an upper limit, but as people age or as we all got older, our kidney function tends to decline over time and we get more medical problems. And so people that step forward and are older and wanting to be a kidney donor, sometimes they cannot proceed because either their kidney function is not high enough or they have multiple medical problems, and that put them potentially at risk of having kidney problems themselves in the future. And in those cases, we then sometimes have to say, well, we really appreciate that you stepped forward, that you wanted to give this gift, but because we don't think it is safe for you to proceed or want to put you at risk of having kidney problems yourself in the future, unfortunately, you cannot proceed with organ donation.
You mentioned early on that the real focus is the patient, and you want certainly the very best outcome for the patient. What else would you say is special about the transplant program at Baylor Scott & White?
I think one of the things that is very special about our transplant program here at Baylor Scott & White is that we continue to try to be innovative and adapt the newest research and newest surgical techniques to benefit our patients. One of the patient populations that we found have been disadvantaged, particularly looking at kidney transplantation, are patients that are severely overweight. And a lot of times these patients didn't end up being listed for kidney transplantation or considered, or had to lose a lot of weight to even be considered to be put on the transplant list. And so a lot of times they got disadvantaged. Even though we know that these patient population also benefits from receiving a kidney transplant. And so in order to improve access for these patients, we're now offering robotic kidney transplant surgery to severely overweight patients. And the benefits are smaller incisions, less wound healing, complications, and then hopefully improving their access to transplant. That's one of the other special things I think about Baylor, that we're always looking for new ways to help our patients.
You know, you mentioned robotic, and we hear a lot about robotics and other forms of surgery. How new is robotics as far as transplants?
Robotics has been around for a while. Robotic surgery has played a role now for a while in transplantation, is by removing kidneys robotically from our donors. This has been actually very well established. We're here at Baylor been doing the donor surgery robotically since 2014, very successfully, because we think really this is the best technique and has the best outcomes and results for our donors. I would say other areas of transplant, it's an ever-growing field. Robotic transplantation now also has been more and more done for implantation in the kidney recipient, particularly, as I mentioned, for patients who are severely overweight. But also on a liver transplant standpoint, we're offering robotic liver resection for our liver donors at Baylor too, which is also still very new and not done at many institutions across the world. And also leads to, I think, the best outcomes for our patients and donors.
You know, you've mentioned quite a few things in the last few years that have really changed some of the transplant. As you look to the future and in the horizon, do you see even more advancement, especially with technology related to kidney or liver transplants?
I think one of the beauties about transplant surgery is that it's a field that continues to evolve and be very open to adapt new things and new techniques. And I think there's still a lot more to come in the future. What exactly that will look like, I'm not sure, but I know it's a field that's still growing and expanding very rapidly.
This has been Dr. Johanna Bayer, an abdominal transplant surgeon at Baylor Scott & White All Saints Medical Center in Fort Worth. Maybe there is somebody in your family or circle of friends who needs an organ, and you might want to listen to this episode again. It's all on our podcast and YouTube channel, The Human Side of Healthcare. We're going to turn our sights on ourselves and talk about getting jobs in healthcare next on The Human Side of Healthcare.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. And we want to talk a little more about choosing healthcare as a career. And we're delighted that we've got Natalie Wilkins with us today. And Natalie serves as the Chief of Staff to the President and CEO of Cook Children's. I will also tell you she serves on the Board of Trustees for the Dallas-Fort Worth Hospital Council. Natalie, welcome to the show.
Thank you, Steve. I'm so glad to be a part of the show.
To our listeners out there, especially if they're pondering a career and they're thinking in terms of health care, can you share with them why you chose healthcare for a career?
That's a great question. I chose healthcare for a few different reasons, but I was motivated early in life. So my father is a physician. So I was inspired and motivated by him and his love for his work in taking care of patients. Also had a mom that was incredibly supportive and always pushing me to do what I wanted to do. When I was in college, I considered a pre-med route, but changed gears along the way. And I was really focused on what I could do to essentially give back and to have a great career at the same time. I thought about a few different routes. I talked to hospital administrators, I talked to nurses and doctors and got their perspectives on their healthcare journeys. And ultimately, I decided that with my business background and with my learnings in the business world and my strong interest in healthcare and having family in healthcare, that would fit really nicely in a healthcare administration world. I would say my parents and some really fantastic mentors helped me get to that decision.
That's great. And I know you've mentioned, and our listeners already now know, you're not on the clinical side, you're on the administrative side. Can you explain to our listeners exactly what is your job entail being Chief of Staff for the President and CEO?
Yes, I'd be glad to. So currently I serve as the Chief of Staff to our President and CEO at Cook Children's, and that's Rick Merrill. And Steve, it's interesting, this Chief of Staff role is becoming more and more popular at health systems and at hospitals and really in businesses. And typically its role is unique to each CEO. Whatever that CEO needs in support of his or her most pressing and important priorities, that's typically what the Chief of Staff is involved with. In my role, I have a great responsibility of bringing together leaders from across our health system to develop and put together strategic partnerships or programs. And probably some of the listeners know about Cook Children's, right? And our world-class facilities and providers in Fort Worth in our 6-county service area. But what people may not know is that Cook Children's has specialty clinics all throughout West Texas and Central Texas, where our specialists travel to see patients in, say, Amarillo and in Lubbock and in San Angelo and in other areas. And we get such good feedback and appreciation from these families that don't have to travel long distances to get to Cook Children's. And oftentimes we have partnerships with these hospitals and these communities. And that's a big part of what I do, is to help bring that pediatric specialty care closer to home. I also have the really fun job of overseeing business development and community relations for Cook Children's. We have a great team actually that covers literally half the state of Texas. So I love my job. It's a great one.
Yeah, it really sounds like it. And you point out one of the differences, not totally, but between children, adolescent, and pediatric hospitals and adult hospitals. And I like the phrase you use, healthcare close to home, because you're dealing with young children in many cases, and they want to be near their parents. Thanks for pointing that out. As you look back and you first entered healthcare, and you had your first job and you worked your way up to now chief of staff. What advice would you give listeners that want to enter healthcare as what skills should they focus on first?
That's a great question. I would say for folks that are getting into healthcare and they're making that first step, one of the best things that they can do is to find a great mentor, and maybe finding even 2 or 3 people that have done great things in the healthcare world, whether it's clinical or non-clinical, that are willing to spend some time with them and just tell them about their journey and to listen and to give great advice. I think that's one of the things that was so important for me starting out as a young careerist in healthcare. I'd also suggest there's so many great associations in Dallas-Fort Worth and Texas that have great learning opportunities and opportunities to give back. Dallas-Fort Worth Hospital Council is one, the Texas Hospital Association, ACHE, the American College of Healthcare Executives, all great organizations that allow for young careerists and experienced careerists too to learn and to give back. Those are 2 things I think I would highly recommend.
You're listening to The Human Side of Healthcare, and we are talking to Natalie Wilkins, who is the Chief of Staff to the President and CEO at Cook Children's Healthcare System, about working in healthcare. Steve?
And many of the people we've talked to said exactly what you did. Have some good mentors to help you shape and develop your style and how you move forward. Speaking of that, Natalie, and you've got a bright future ahead of you, but as you look back thus far in your career, what would you say are some of the greatest highlights that you could say gave you true satisfaction that you were in healthcare?
I think it's just the opportunity to help others at the core of what I do. That can come in a lot of different perspectives, whether it's developing programs to bring pediatric care closer to home to improve the care model. For example, help an up-and-coming leader or staff member prepare for their future, to be alongside them and guide them as they're trying to figure out what their next step is and what they ultimately want to be. That brings me great satisfaction. Too, it's the simple things, visiting with patients and families in the hospital or in a clinic, just understanding what they're going through. Just those conversations with patients and families are so meaningful to me. Of course, as an administrator, I'm there to listen, right? And just to guide them along the way. But it's just very meaningful to me when I can have an interaction with a patient and a family that really hits close to home.
As you talk to a lot of the young people, and I know you do because I know as far as bringing in interns, residents, especially if they're getting a master's in hospital administration, what do you sometimes hear is the greatest misconception of a career in healthcare?
I think when a lot of people think about careers in healthcare, their minds kind of typically go to doctors or nurses or social workers. And a lot of times people don't think of the business side of healthcare, whether that's hospital administration, whether that's being on the finance or marketing team for a hospital or health system. I think a lot of times people don't think of all of the things that there are available in the healthcare world, even outside of the clinical world. I would say to those kind of thinking about healthcare, we always need clinicians, right? I mean, we're always in need of great staff, nurses, doctors. So if that's a route for you, that's great. But if not, there's so many other options to think about in that healthcare spectrum.
Natalie, I think one of the things that the general public sometimes loses sight of, and I was thinking of it as you were describing your footprint, Amarillo, West Texas, other parts of Texas, opening clinics. You employ workers, you have staff that go into those communities. Sometimes people may not know that healthcare and hospitals stimulate the economy and help provide jobs. When you look at it from a business point of view, the economic impact, say, of Cook Children's, do you have any thoughts for our listeners on why that also should be thought of when they're considering a career?
Yeah, I think hospitals and health systems have a tremendous footprint, whether it's by way of hiring, by way of the supplies that we purchase. I know also at Cook Children's and many of the hospitals, we have programs that directly benefit members of the community and typically the most vulnerable members of our community. We have targeted programs that we build so that children and families are receiving the best pediatric health care possible in our community. So I think at Cook Children's, we take great pride in delivering on that promise. That's what we have here at Cook Children's is our promise, and knowing that life of every child is sacred. It's our promise to take care of the children in our care in our communities. And so we always look for opportunities to deliver on that promise.
We're talking here with Natalie Wilkins, who is the Chief of Staff to the President and CEO at Cook Children's Healthcare System, a position, by the way, as she mentioned earlier in the interview, that is now both more common and more important in many hospitals. And when we come back, we're going to extend that and talk about the myriad of opportunities there are to work in a hospital. Next on the human side of healthcare.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're talking with Natalie Wilkins, whose position is the Chief of Staff to the President and CEO at Cook Children's Healthcare System, one of the many administrative roles in hospitals that has actually expanded over the last several years. So, Natalie, I'm wondering, to kick this segment off, can you tell us more about the expanded role of Chief of Staff?
Yes, I would be glad to. I think that one of the main roles of a Chief of Staff is that this person has great insight to operations and what goes on all throughout the organization. So a lot of times I find myself working closely with leaders from our physician network and our medical center and our health plan. That's a big part of what I do is pulling together all the right people and all the right pieces so that we can make informed and strategic decisions.
So I'm thinking, too, of, as you said, your CEO, Rick Merrill, then doesn't have to do that. He can rely on you knowing that that program is being pushed out and implemented the way that he would want it done without having to actually do it.
That's right. That's exactly right. Having someone that he can trust to execute on behalf of him while keeping him informed and checking in along the way and seeing how things are going. That's absolutely right. There's a lot of trust there between a president and their chief of staff that needs to be built. It's quite an honor and a lot of fun at the same time.
Yeah, that's a high-level position with a lot of responsibility. And I'm thinking about also some of these other areas in hospitals that have developed over the last, it's expanding now, maybe 15 or 20 years, but things like the nurse navigator, or now we have in various ways and forms patient liaisons or patient concierge type positions. Are there some other areas of the hospital that kind of like yours that may not have existed 5 or 10 years ago?
Yeah, I think healthcare is such a dynamic industry that things are always changing. I think probably been in existence longer than 10 years, but the patient and customer experience, there's so much focus on the patient experience, and we're getting better at measuring the patient experience and also developing programs that help us improve the patient experience. I think that's one piece that's really developed and grown over the last 10 to 15 years, and I think hospitals and healthcare systems are getting better at identifying opportunities and implementing new programs and strategies to help listen to our patients and families and get better at serving them.
Yeah, that's great. Steve, I'd love for you to lean into this one as well, but Natalie is perfect for this, to do this. We've never done this here on the human side of healthcare. But for people that are thinking about going to work for a hospital, let's just kick around some of the myriad of areas that people would not have thought of that would be potential jobs for them at a hospital. That's all under the roof of the facility. And I'll tell you where I'm going with this. Things like food service, and even beyond that, dietitians and registered nutritionists who put the food together. But then there's also the preparation of the food, the cooking, the kitchen. So you could go to work for a restaurant, you could go to work for a hospital. It's in the same area. Housekeeping is another. And then IT and technology. I mean, that's a whole division right there, right? I was thinking biomedical. That's my son's area. If you had a more of a religious preference and didn't want to go to work for a church, you could be a chaplain. What are some of the other areas that you guys would throw down that might go to that list?
You covered a lot of great ones. I would say marketing and communications are really a strong deliverable of a hospital and a healthcare system. You need really good internal communications within the hospital, but you also need good external communications too with the community. And you need a good finance team, right? You need someone that's going to be constantly looking at the numbers and evaluating how things are going. One thing that's really a great job, especially the pediatric world, is our child life specialist. So a child life specialist is essentially supporting patients through these potentially sometimes challenging times. So working with them through play therapy. We have a dog therapy program where we have 6 dogs, canines, that allow for therapy and playtime with the children as they're going through some challenging times in the hospital. And so our child life therapist and specialists, they allow for children to have special time to play and to heal at the same time by doing things that they want to do.
I think Natalie's done a great job. I can think of a few others, Thomas. Hospitals are big governmental contractors, and a lot of people don't look at that way. Now, Natalie's not going to have a lot of Medicare, but she is going to have Medicaid and she is going to have CHIP. And when you sign those contracts with governmental entities, there are rules and regulations you have to follow. And when you talk about the finance like Natalie did, there are special people that know how to bill Medicare, Medicaid, do the cost reports, which is kind of like a big report that you have to do with the federal government every year. And you can have great careers if you like business, finance, and that type of thing. Another thing that brings into play is compliance. Hospitals want to make sure they follow all rules, all regulations, and they have a compliance team and a compliance office so that they ensure that they don't misstep in any way. If you like IT, as you mentioned, Thomas, there's so many areas of it, like security. IT security is so important in hospitals to protect the integrity of the patient's record. And also governmental affairs. We have to deal with new laws that come out of Austin, new laws that come out of Washington. So you could be a great leader in a hospital system, and all you really do is deal with legal matters associated with governmental affairs, and then chief legal counsel. Every hospital system has to have good in-house legal counsel because there's so many contracts you do. I could go on, but I just want to say, Thomas, you asked a great question. In healthcare, there's almost a job for everyone.
It's a city within a city, isn't it?
It really is. And you mentioned housekeeping, and housekeeping is one of the most important jobs in a hospital because they do infection control, the cleanliness of the facility. And when I worked in a hospital, I used to go around every day and thank them for the job they did.
Oh, yes. It's extremely important. Our environmental services department and staff members are so critical to what we do every day in the hospital and keeping everything clean and at the highest functioning way possible.
Do you have any final thoughts you'd like to share with them?
I would say I'd go back to the mentor comment and finding folks that have great healthcare careers and just asking them questions and getting advice from them. I would also say a great opportunity if you're considering a job in healthcare is contacting your local hospital and volunteering for that hospital or for that clinic. Volunteering gives you a chance to give back to the hospital, but also kind of gives you an insight into what goes on inside the hospital. A great way to learn more as you're considering that opportunity. The last thing I would say is not to worry too much about what the end game is. Just think about what the best next step is and getting that start. I would highly recommend a career in healthcare. It's been very gratifying for me and would just wish the best to listeners that are going in that direction.
Natalie Wilkins and Steve Love, what a great insight and peek into the many opportunities to work in a hospital. Steve, let's close it out.
Thanks, Thomas. What a great show. You know, it's February, and I know that spring is around the corner, but we still got to be careful with some of these respiratory infections. So please take care of yourself. And thank you for listening. Join us next week for another Human Side of Healthcare.